I think that brings with you, an interesting perspective that you actually see a bunch of different people do a lot of these procedures. And certainly I've seen trainees bring that perspective to a wet lab.
Welcome to Season 6 of EyeCan, a podcast about ophthalmology through a uniquely Canadian lens. EyeCan is co-hosted by me, Patty Sahed, and Heather O'Donnell. Throughout the season, we'll have guest co-hosts for some of our shows. We will share our experiences as ophthalmologists today and tackle some of the challenges we face as healthcare providers. Season 6 of EyeCan is brought to you by Astellas Pharma Canada and Johnson & Johnson Vision. We thank them for their support. Surgical Skills Transfer Courses, or STCs, are hands-on educational sessions that provide practical training in surgical techniques, diagnostics, and clinical management. Led by COS selected experienced physicians, they give participants direct experience with real-world tools and scenarios. By bridging the gap between theory and practice, STCs help clinicians refine their skills, adopt new innovations, and ultimately improve patient care. In this episode of EyeCan, we welcome guests Dr. Monique Monroe, current chair of the STC program at COS, and Dr. Cody Lowe, incoming co-chair for STC program at COS. Dr. Monique Monroe is a multi-fellowship trained medical retina and surgical retina specialist who subspecializes in uveitis and pediatric retina. Following medical school and ophthalmology residency in Calgary, she went on to complete a medical retina and uveitis fellowship at the Illinois Eye and Ear Infirmary at the University of Illinois at Chicago. She was then accepted for a competitive surgical retina fellowship at the same institution. Dr. Monroe has been providing care in the Calgary Health region since 2022. She serves on Canadian and international ophthalmology committees and avidly participates in research. Dr. Cody Lowe is an ophthalmology resident at the University of Ottawa. He earned his MD and DSc in pharmacology from the University of British Columbia, graduating as a Westbrook Scholar. Passionate about medical education, he has held several national leadership roles, including president of the Council of Canadian Ophthalmology Residents and lead organizer of the inaugural Medical Student Symposium at the 2023 COS annual meeting. In 2027, along with Dr. Kian Majedi, he will assume the co-chair role of COS's STC program. Monique and Cody, I'm so happy to have this chat with you about STCs. So welcome to EyeCan, and we're going to jump right into our conversation. So at COS, the skills transfer courses are always among the most popular sessions, probably because they give us something we can apply the coming Monday morning after the meeting, either in the clinic or the OR. I'd love to explore how these courses actually help surgeons at different stages of their career. So for residents early in their surgical journey, Cody, what do you think it is about skills transfer courses that really helps build that confidence in the OR?
Thanks, Dr. Seven. First, I should just say it's a real honor to be here on the podcast. I've been a fan of EyeCan since I was a medical student. And so it's a real full circle moment to be here today. And secondly, I just want to make sure I acknowledge Dr. Kian Majedi, who's currently a cornea fellow in the US, who really paved the way for resident involvement in the STC curriculum when he was a resident in Calgary. And so I can't be more excited to be sharing the role of chair with him in the coming years, building on the successes of Dr. Monroe and the team. In terms of your question, I think for residents and trainees in particular, the STCs provide a really valuable opportunity for trainees to accelerate their confidence in the operating room. I think we can all attest that our preparation before the operating room really helps determine our success in surgery, particularly when we're trying something new or when we're in the learning stages of our career. Most, if not all, residency programs likely already have some form of simulation as part of their training. But I think for trainees, it can be quite valuable getting exposure to things like the STC courses because they provide really a different way of doing things. You get some instruction from folks who are outside of your normal environment in your training program. And it also, I think, helps teach you to be flexible in terms of equipment and just being adaptable and different way of doing things. The other thing I'd highlight for trainees is you'll notice with the STC curriculum, it really spans multiple different subspecialties of ophthalmology. So I think for residents coming to the COS meeting, depending on where you're at in your training, you may have not had surgical exposure to all the different subspecialties. And so taking an STC course may help you accelerate or give a preview to some of the different subspecialties and you may discover, for example, that you have a real knack for glaucoma surgery. And so I think in that way, this STC courses can really help trainees accelerate their professional development and help expose them to areas of ophthalmology that they may not previously have been exposed to.
Awesome. So, I'm hearing your perspective about the trainees experience, and I do think that, we often think of STCs as being geared towards trainees or early career ophthalmologists, but I've been amazed about how many experienced surgeons attend them as well. And some of my own surgical mentors have been present at glaucoma STCs where I'm participating and learning about some of the new techniques. So, Monique, from your perspective, what do you think keeps established surgeons coming back to STCs?
Right. I had the same experience when I saw who were the attendees, and a lot of them were my teachers or my peers. And so, even for the most experienced of surgeons, STCs are really about having a safe place to maybe try something new or something you just may not get a lot of exposure to. So when you're learning about a new technique or technology, it's really not, we all understand it and understand the concepts as experienced surgeons, but it's about getting comfortable with it. And these courses let you slow things down, practice, refine your approach without any patient risk. And for example, I loved the simulator as a retina fellow and sometimes would even create small complication and challenging situations that you had to deal with, all before you're taking care of a real physical patient. So you're also learning from multiple experts, which is so special in ophthalmology since we do tend to operate on our own or with a very small peer-to-peer community. So this isn't something we do day to day. And sometimes early in practice, I'll still just go to a colleague's OR, even though it's surgeries I do and feel comfortable with, but just to see, hey, how does someone else do something? Where do they put their trocars? Where do they make an ILM flap? And just try to improve efficiency and patient care for those I'm taking care of. The other thing is sometimes the equipment we're using is disposable or very costly. Example, a lot of the glaucoma implant. This allows more reasonable access for a surgeon in a controlled and safe environment before implementing it in real world practice. And you can have one-on-one time with not just the medical expert, but also industry, which I think can be very valuable. So really, I think what I'm trying to say, it's about building confidence and what you bring to the OR so it feels familiar and controlled.
I like that. And the other interesting thing is many of us have had the experience of watching this amazing surgical video, either online or at a conference, and thinking like, wow, that's pretty straightforward. I think I can do that. And then realizing in the OR that it's definitely not so simple. And so how do you feel skills transfer courses help kind of bridge that gap between observing this technique in a video and actually feeling comfortable performing it independently?
Right. It's not that long ago I was a fellow, and watching a surgery can certainly make something straightforward, but it is very different when you're the one holding the instruments. And those who train fellows know this very well. And I try to, encourage my trainees, like, yes, this is it looks easy, but when you're in the hot seat, it can be a little bit trickier. So STCs can help bridge that gap by letting you actually do the procedure with time and guidance. You get real-time feedback. You can make mistakes, fix them, throw out that model, try again, ask for some feedback in a safe environment. So that's where you really build the feel for it, the judgment and the confidence. So by the end of it, it's not just something you've seen, it's something you've started doing as your own skill. And I don't know about you, but I'm sure a lot of surgeons would feel the same way. You're going to feel more confident knowing that you tried something, even if it's in a simulatory setting, before going in and operating on a real patient.
Yeah, I agree with that. I find that our residents, after, we have a MIGS wet lab at McGill, and it's amazing how much more comfortable they are doing the angle surgery after that wet lab. Even something simple like, putting a goni in one hand and the surgical hand in another, and operating that way is a challenge. And to just have the opportunity to practice that in a wet lab setting is so useful. So for residents or surgeons looking through the COS program, Cody, what is your advice as to what they should be looking for in a high quality skills transfer course? there's certain characteristics they should be looking for? Is it the faculty, the structure, the topic? Like, how would you guide somebody trying to decide which STC to choose?
Yeah, great question. I can speak to some of the aspects that the organizing committee tries to keep top of mind when designing these courses to help make sure that participants get the best value out of these sessions. I think one thing we really try to focus on is the fidelity of the models that we're working on. So our committee meets regularly with the course directors to try to make the simulation as representative to what you may encounter in real life as possible. And so one example is this year we have an oculoplastic session where we're actually bringing in pig heads to act as a model for human skin. And I know when I joined this committee, at least, one of the things that was really interesting to me is how much logistics go into setting up a lab like this. The COS receives these pig heads directly from a local butcher. It's stored on site. It's thawed just the right temperature and consistency so that it's most representative to human skin. So that was something I was really impressed when learning about the different sessions we're hosting, just to focus on fidelity of the model and trying to make it as representative as possible. I think the other aspect when choosing a course is the fact that the courses at the COS meeting are all directed by physicians. And so these are typically subspecialists in their respective fields, and they brainstorm what content is going to be most relevant for participants to learn. And each of the different courses has an intended audience. So many of the courses, even though they have a subspecialty focus, are intended for comprehensive ophthalmologists or residents, or in some cases for subspecialists. And I think we try to clearly define the learning objectives based on that intended audience. And so, for example, in the glaucoma wet lab, it's very relevant for the comprehensive ophthalmologist. We intentionally choose devices and technologies that a comprehensive ophthalmologist could realistically and practically incorporate into their practice. Whereas on the other hand, our cornea session this year is based on additive corneal technologies and surgeries. And we'll actually have a femtosecond laser on site. And so that session is much more geared towards subspecialists. And so I think that's something we really try to be clear about in terms of who the intended audience is for the intended session. The last point I'll highlight is the instructors for the various wet labs. I think we're really fortunate at the COS is that we have a wonderful community of Canadian ophthalmologists who contribute their time being instructors to these sessions. So for many of the sessions, we have a near, in some cases, one-to-one instructor to participant ratio. And speaking from personal experience, I found it to be wonderful as a trainee coming to these sessions because you're getting taught by some internationally renowned experts in these procedures. And it's been wonderful meeting subspecialists at different programs across Canada, especially if you're considering applying to fellowship, for example. Getting to meet the instructors who are often involved in these fellowship or training programs, I think has been an incredible experience and sort of an added benefit, especially for trainees attending some of these courses.
And so in the real world, surgery rarely goes exactly as planned. And I know that often for wet labs, we're exposing colleagues to kind of the routine aspect of doing that specific surgery just so that they get their hands wet. But, of course, in the real world, they are going to run into occasional complications. And so, Monique, how do these hands-on courses help ophthalmologists go beyond kind of the routine operation and prepare for some of the common challenges or complications that will inevitably happen at some point in practice?
Right. Yeah, that's a good question and something we all have to deal with and be prepared for. And what I like about these courses is I think that they're very honest. It's a small setting, it's a safe setting. And so they certainly are not just about perfect surgery. They focus on challenges, what happens when things don't go perfectly, and you get to ask someone who may do this procedure more often than you or all day, every day, and how they deal with that challenge. So it's a very unique, special circumstance where you get to really pick someone's brain, but also maybe even purposefully practice that complication. So surgeons get to go through, think how to adapt, troubleshoot, and make decisions in a moment. I think you can sense a theme with my answers in a safe and controlled way and not dealing with an issue for the first time, hopefully in a real patient. So there's a lot of practical insight you gain from the faculty and these little tips. You really can only learn through experience. I try to hammer that home with my fellows often. I talk about what are you going to do if this happens, if you pull an infusion line and the eye's soft, what are you going to do? And it teaches, better surgeons, safer surgeons who are cool under pressure. So you get to network and build these relationships. And now you may even have someone to call with questions if you have something encounter who you may have met at a wet lab. And that's very unique in Canada. We're a strong community, but also a small community in ophthalmology. And so it's very special. So I think people feel leaving more prepared, not just for the ideal case, but the unexpected as well. And this all just leads back to better care for Canadians.
I'd love to double click on that idea of simulating complications. So do either of you have examples of a complication that's easy to simulate or a challenge that's easy to simulate and has successfully been done in any of the STCs that you've come across? Any specific examples? That would be really fun to hear about. Just because it's a complication that's not real, right? So anything that comes to mind, I'm trying to think of in the glaucoma wet labs as well. It'd be fun to share kind of a reproducible challenge or complication in a wet lab setting.
Reproducible complication that I've done myself or an assistant is pulling the infusion line from the eye during vitrectomy. We're often rotating the eye, scleral depressing. It's very easy to do, even when someone is being very astute and careful. As you can imagine, if an eye is filled with air, not just fluid, or you've even taken out all the trocars, this eye can be very unstable and very soft. So even injecting filtered air or BSS can be very difficult. This would be a very reproducible circumstance and very real world, even with porcine eye models. And so we can reproduce that and talk about steps to take to act fast to minimize that suprachoroidal hemorrhage, minimize those complications at the end of a case that has otherwise gone beautifully. So this, I've been dying to actually create a retina-focused wet lab, but as you can imagine, it's a little bit challenging. But something like that could be very interesting for future STCs. How to manage the deflating eye.
Yeah. In the glaucoma wet labs, one of the things that's been easy to reproduce because it just happens so often with early surgeons or learners is this idea of like momentum. And then once you implant the device, you kind of have this flick, and that can be dangerous. You can either, touch the cornea or touch the iris or ciliary body, or you can amputate whatever device you're putting in. And so it's so nice. As soon as you see the momentum, it's like a wonderful opportunity. Like you see that momentum. So what's happening there is you still have momentum when you're releasing the device. And so let's try that again and make sure that before you release, you have this like moment of intention where you remove all that momentum. And, my typical line is like, relax your wrist, remove the tension from the wrist, from the shoulders, from the elbow, make sure there's no tension at all. Your hand is just kind of floating in the air before you release the device. And it just makes that moment so much smoother and safer. And it's something really easy to show in the wet lab setting rather than in the eye. So yeah, those are fun examples and fun situations to go through in a wet lab setting.
EyeCan wants to know what you think. Please send your comments on today's episode or any suggestions you may have for topics or features to communications@cos-sco.ca, and we'll try to incorporate them into future episodes.
EyeCan veut savoir ce que vous en pensez. Veuillez envoyer vos commentaires sur le balado d'aujourd'hui ou vos recommandations de sujets à communication@cos-sco.ca et nous essaierons de les intégrer dans les prochains épisodes.
Hi, my name is Deepa Yoganathan, and I listen to the EyeCan podcast.
Yeah, one of the unique aspects of the STCs that I found is really the mix of participants. So like you've got, as we mentioned before, residents, early career surgeons, some very experienced surgeons, kind of all learning together. And so, Cody, what are your thoughts about how that peer interaction across kind of the spectrum of the ophthalmologist journey how does that influence the educational experience, you think?
Yeah, for sure. I think that's a great point. Certainly at an STC lab, there's going to be a large flow of knowledge from instructor to participant. But speaking from personal experience, I think there's a lot of transfer that happens also from the trainees upward and even sort of horizontally between the person you sit beside, for example, at one of these labs. I think a lot of people in training and early in practice have the benefit of actually getting to watch a lot of people operate through their training, a lot of different attending surgeons in your residency program and your mentors in fellowship. And so, I think that brings with you, an interesting perspective that you actually see a bunch of different people do a lot of these procedures. And certainly I've seen trainees bring that perspective to a wet lab. And then on the other end of the spectrum, more established surgeons obviously bring their wealth of, firsthand experience as well. And I have found that in many of these sessions, there's a lot of collaboration between the people of different career stages, sharing their experience with different procedures, sharing how people do things at their institution, for example. And so I think the STC labs really provide a venue for our Canadian ophthalmology community to really cross-pollinate a lot of these different ideas and techniques and way of doing things. And so I think there's certainly a lot of benefit there. And I think as a trainee, certainly a lot of people that I've met at the STC, either being taught by one of the instructors or even the people you sit beside, at the lab. Many people I've met at these sessions have become people I would consider mentors in ophthalmology. And so I certainly like the STC for the social aspect, so to speak, of getting to connect with your colleagues in that sort of setting.
I'd like to pivot to talking about this rapid evolution we're seeing in surgical simulation, digital visualization, and even some AI-supported tools. And so, Monique, how are these technologies changing the way surgeons are preparing for live surgery now, and how are they being incorporated, if at all, into the STCs?
Right. So yeah, simulation and wet labs are huge. They get you practicing before you've even hit live surgery setting. And now with newer technology like digital visualization, even early AI tools, you can get much more precise feedback on how you're doing. And so it really helps surgeons refine their technique in a measurable way. So all of these things, our goal is to improve readiness and confidence while keeping patient safety at a center. I think with training right now with simulation, we have really made great progress in terms of cataract surgery and retina surgery models. And I think these things go hand in hand, the simulators and the wet lab. And I find where one fails, that's where the other one sings. And so I found using the VR simulators as a fellow, I could just hit repeat multiple times, really learn that muscle memory, for example, for doing retinal laser. They have great anti-tremor training modules, for example. But the one thing they always lack is it doesn't have that tactile feedback, and the ergonomics aren't there. The microscope is, crystal clear because it's a beautiful TV screen. So that's where I think our STC wet labs really fill in a nice gap in terms of how we incorporate this. It really varies session by session. Patrick Gooey, when he was course chair, would often bring one of his glaucoma simulator modules, which I thought was great. And year after year, when I go to different conferences, I'm also seeing more VR focused AI and simulation. So hopefully we can maybe start to introduce things a little bit more as Cody and Keon take the lead. And I'm looking forward to that. You guys are going to do an excellent job. And maybe just to pivot for 1 second, while it's a nice digression, I really loved my role in this. I think it's the perfect leadership position for those interested in becoming more active in COS in the community. You get to meet a lot of people you wouldn't have otherwise met in our own little subspecialty silos. It's so much fun, so social. Everybody is so relaxed. And I think it's a great stepping stone, maybe to other leadership roles. So it sounds like from Cody's CV, you'd make an excellent program director someday. And that's why I'm bowing out, because I'll be taking care of that in Calgary. So I couldn't be happier for Cody and Keon.
Thanks a lot. It's big shoes to fill, but we're looking forward to it.
I love that. And I do agree. I think I think Cody and Keon are going to do a fantastic job for this important part of the COS. So, Cody, for someone considering their first or their next skills transfer course, do you have any advice for them to help them get the most out of the experience? What should they be doing or thinking about or preparing kind of in the days preceding the STC?
Yeah, it's a great question. From my personal experience, one piece of advice I could offer is try to come prepared with lots of questions. Nowadays, as Dr. Monroe was alluding to, there's so many resources outside the context of a hands-on session to learn about surgery, whether that be through YouTube videos. There's a lot of surgical teaching done on social media now. And so there's many different ways you can learn the sort of steps and the sort of basics of a particular surgical procedure. And so I'd highly recommend, just familiarizing yourself with that before coming to the lab. Because I think from my personal experience, coming to the lab with that basic foundation, I think really allows you to ask some informed questions and get some really nuanced feedback about how you can improve your ergonomics, getting some feedback on your hand positioning and how you can make your movements more efficient. I think you get much more from the lab if you come with some of those basics down, especially because, as we mentioned, many of these instructors, do these procedures day in and day out. Very often are teaching these procedures in the OR in real life to trainees. And so they are familiar with some of the bumps along the learning curve and know how to coach people through that. And so I found coming in with the basics already down so that you can really have a higher level discussion about, steps, how to manage complications, as we were mentioning. I think you get more out of it like that. So I know the meeting is busy. There's a lot of sessions to attend, people to meet, and things to do. But certainly, if you can find the time, I think the STC courses are really a great part of the meeting. Like Dr. Monroe said, they're a ton of fun. And if you come prepared, I think you get a lot out of the sessions for sure.
Well, let's inspire our listeners with some of the biggest hits in STCs. It might be helpful for listeners to hear examples of the kinds of topics or formats of STCs that really resonated. So, Monique, were there particular skill transfer courses over the years that were especially popular, impactful? What are the favorites?
I'd say MIGS is a constant favorite. We bring it back nearly every year, I think for multiple reasons. The technology is always changing. It may be something, to go back to some of our prior questions, you want to get exposure before you go in and implement some of these more expensive devices or technically nuanced and challenging devices. So I love that. And it's if you've ever been to the MIG session, it's really fun. It's like lightning round glaucoma in my mind. You have these multiple stations, surgeons are bouncing around, like bebopping. I'm trying to figure out, is everybody happy? What's going on here? And you're really just kind of choosing your own adventure as a glaucoma specialist and tailoring the STC to what your particular needs are. And I think that's great because sometimes we all go to a session and you're like, well, I liked this part of it, but most of it wasn't really for me. I know how to do these things, or, we leave feeling a little dissatisfied, but I certainly do not see that happening in the MIG session. I think that, the new introduction of oculoplastics and suturing has been very fun and exciting. And we've introduced, porcine models to the wet labs, and people are very engaged and excited. And that's, coming back for another year. I myself am particularly excited for iris suturing this year. I think we've all dealt with, I'm going to call it misbehaving iris, no matter what specialty we're in or traumas. And so I'm particularly excited for that. But I think the ones that are most popular are really the ones that surgeons can take like straight back into their practice right away. I think, Cody, the best thing to take away from this interview is come with questions. It's going to be so much more fruitful that way. And yeah, we've seen a lot of surgeons go on to actually incorporate what they've learned. I myself certainly included, which is incredibly rewarding. And I love observing as a course chair. And they aren't just educational, they translate into how we actually do things. Cody, do you have any favorites over the past couple of years you've been working with me, or ones you think people are excited about?
Yeah, I'd echo that. The MIGS one is super fast paced. I think, that one's always super fun. Yeah, M6 was another one that I've done in the past, which I think is, so relevant for people that do cataract surgery. And especially as a trainee, nowadays we really don't get exposure to those types of techniques for cataract surgery. But certainly, there are going to be a few cases in your career where it comes in pretty handy. And certainly for international work, it's really nice as well. So the M6 lab is really good. And there's a reduced rate for residents this year for that lab as well. So that's one that I've really enjoyed in the past.
I actually did that kind of different, like modified technique of that very unexpectedly as a retina surgeon. And I felt actually very calm and collected despite never having to do that, just by it being a fly on the wall at that STC. So you unlocked a memory there.
Before we wrap up, I'd like to finish with a quick lightning round. So these are short questions meant to be short answers. So really just the first thing that comes to mind. So I'll start with you, Monique. It sounds like you've just come off a busy retina call, which I imagine was hectic. So do you have like a favorite way to recharge after a busy call?
Right. I'm at a phase in my life where recharging is funny, but spending time with my family. So my toddler definitely keeps life interesting. I'm very surprised him and my dog have not made a guest appearance during this episode. I love going for walks with my dog, and I find that very cathartic and relaxing.
Yeah, I think it's the fact that I asked you how to recharge when you have a toddler at home is probably a moot point, right? It's what's easier, retina call or taking care of a toddler? I'm not sure, but anyway,
Retina
keep it up.
call.
Retina call is easier. I believe you. I believe you. Cody, you're in your final year of residency, so you've had a set of years in medical training with, I'm sure, busy schedules. So what's your favorite productivity hack that you've acquired over your medical training?
Yeah, that's a really great question, because it certainly had to come in handy during residency. I listened to a podcast recently, and one of the tips that they had was something called time blocking. And so the idea is that any task will expand to the amount of time that you give it. And so, I try to time myself checking my email, because otherwise it just seems like you've been on email for hours on end and you haven't done anything else that was on your to-do list. Same thing with writing papers. Certainly have before spent the entire day and have not written much down on the paper. And so intentionally blocking off a few hours that I'm going to try to finish as much of this manuscript as I can has really helped keep me motivated to try to make the best use of your time. So for those who feel like they need to up their productivity game, I'd certainly recommend looking into time blocking, because it's helped me a lot try to fit everything in.
I love that. Nir Eyal is a productivity leader who talks a lot about time blocking, and I think that's useful. Before it was even called time blocking, I remember in residency in preparation for Royal College, I was very clear on how much time I spent on each manual, right, as I prepared it. So let's say, in the beginning of R5, I said, okay, I'm going to do 2 weeks per manual. And then the closer I got to the Royal College, that period of time would just get shorter and shorter. Because I found until I did that, I would spend on one manual, I'd be there for 4 months, and then, 4 months have passed and you still got another 7 manuals to go through. So I love that. What a great piece of advice for our listeners. Monique, if you were not a retina specialist, what specialty would you have chosen, or what subspecialty would you have chosen?
That's a good question, because I would say uveitis, but then I did that too.
You do that as well, yeah.
I loved glaucoma, and I'm not just saying that because you're our host. There was a period of time where, I was really considering that. I think I liked it so much because I like testing and I like imaging, and so glaucoma has a lot of that. And I think, what just really swayed me was I think a lot of it's at the end of the day, sometimes the surgeries. And, I like all that space to swim around in the vitreous cavity. It's very freeing.
If it means anything to you, I was a retina keener before I switched to glaucoma.
See?
So,
Yeah, there's a
there's something magical about retina, which I understand, but I'm so happy with my choice. With glaucoma,
I wasn't very good with sclera. Like cutting down the traps for I can't tell you why just gave me a lot of anxiety. For some reason, scleral buckles and choroidal drainage. You know why? Because if you do suprachoroidal drainage, you mean to punch through that area.
There you go. Exactly.
There we go.
Cody, when it comes to fitness, are you do you track things, or do you go with the flow in terms of how hard you go with your fitness?
I am a tracker. So I was an Apple Watch user for a long time. I recently got a Whoop. Been really interesting, actually. It does some interesting sleep analyses, and it correlates to how much caffeine you've had, all this sort of stuff. And I've worn it during the OR too. It tracks your heart rate. So that's been one fitness thing I've changed over the past year. And then the other trend I've popped on recently is high rocks. And so my goal for this year is to hopefully finish a high rocks race at the end of the year. So that's been something that has been really got me through Royal College study leave, having a fitness goal to keep myself active.
Amazing. My Royal College year was probably my healthiest year ever. Just, as you said, otherwise you go crazy. And I kind of just forced myself to have, fitness touch points on a daily basis as a break from studying. So I love that. I'm so happy to hear that. Monique, what was the best advice you received during fellowship?
There was so many. I'm going to do two. One's a little bit offside, but I think what the attending was trying to say was very good, and it actually imparts a lot of patience with others and with. He said, "People aren't as smart as you." He said, "Someone said this to me when I was a fellow, and I'm going to say it to you." And what seems easy for you to understand because you do it all day, every day, might not be for another person, and that's okay. And it'll just, help you kind of give some understanding. And so the wording was a little bit questionable, but I think the message was really sound. And anytime, I have a moment of frustration, whether it's with a referral that I think could have been better, whether it's with a patient who, didn't take their drops as instructed. I just think, like I do this all day, every day. It's really easy for me. It's like a fish in water, but this is all really new for, another consultant sending you a referral. They may not see this as often. A patient, this is definitely brand new for them. So I think it's just really helped build a good peer-to-peer relationships and patient-doctor relationships for me, even early in practice. So that was really wonderful. I think in terms of wet lab, a more practical thing that kind of goes back to why we're talking today is how to deal with complications. My other attending, I can't remember what happened in the OR, but something did, and he just said, "You deal with it. You acknowledge it, you decide how you're going to manage it, that's it, and you move on." And I loved that. It really took the emotion out of it. And I think we tend to unknowingly make it about ourselves. How did this reflect on me? Is my colleague going to judge me for this? Is the patient going to be mad at me? And what all of those thoughts have in common is the word me. And not really the patient. So that's what the message was from my attending in fellowship, was make it about the patient, set the emotions aside, and figure out how you're going to deal with it and how you're going to fix it. And I just loved both of those pieces of advice. It just made me a better peer and doctor.
And the other thing to layer onto that is that the next patient also needs you, right? So like the acknowledging and then moving on, right? Especially in the OR setting, is that you need to manage this, and then you need to be able to take care of the other patients who are expecting you to give them your best. So that's really wonderful. Cody, my last question for you is, part of this is selfish as a resident and fellow educator. I'd love to hear your perspective. And when you were talking about taking your tracker to the OR, I wonder if you have certain teachers that allow your heart rate to stay lower than others. And the question that I want to ask is, are there teaching styles, whether it's in the OR or the clinic, that have really helped you reach your full potential in terms of the impact of learning in those particular days? And so are there themes and teaching styles that you can share with us that you have found work best for you and your peers?
Yeah, it's interesting. It's an interesting question. And as I come to the final months of residency, it's something I've sort of been reflecting on. Sort of the stages I think you go through as a resident. And I think as I kind of look back, I appreciate many of my residency teachers for different reasons. And so, a couple of highlights that I've noticed at least is that, there are certainly teachers that are very hands-on. And I'm sure everyone can kind of think back to a residency mentor that had those characteristics. And, I think looking back, certainly there was times in my training where I really appreciated someone was like right beside you, told you exactly where to put your hand, exactly what to do, especially when maybe you're dealing with something a bit stressful. But certainly I think on the other end of the spectrum, there are teachers that are more, hands off, will not say anything, let you sort of sort out your own situation, what you want to do, help you develop your decision making. And I think I've come to appreciate both ends of that spectrum and in between, because I think at different points in your training, there's value to really take from both of those styles. And so certainly, coming to the end of residency and certainly for those in fellowship, I think there's value when you're, preparing for that transition into operating independently, having staff who sort of let you fly on your own and try to simulate that experience of having to make a decision and use your training to come to something that's going to be safe for the patient. I think has been really valuable for me, at least in these final months of residency. So it's a great question because, certainly at different points in my training, you kind of need different aspects of your teachers.
I love that. I often tell learners who are kind of talking about the pros and cons of the different teaching styles that like, you need all of it, you need all of it. You need the people who are barking down your, are barking in your ear, telling you every little detail, and other people that say nothing at all, And so that's really wonderful perspective. So, well, Cody and Monique, thanks for sharing, both all of your experience about STCs and also some of the personal stories that you just shared now. And, the work you're doing with STCs is so important. It's such a critical part of what we offer attendees to the COS annual meeting. So thank you for your leadership, your creativity, and your commitment to the STC courses. And thanks for sharing your insights today. This has been wonderful.
Thank you.
Thanks.
Yeah, I've really looked forward or had a great time the past 3 years.
Yeah, thanks so much. It's been a ton of fun and looking forward to the STCs in the coming years.
Thank you for joining us for this episode. We look forward to bringing you more engaging content over the coming months.
Merci de vous être joint à nous pour cet épisode. Nous avons hâte de vous proposer d'autres contenus captivants au cours des prochains mois.
EyeCan wants to know what you think. Please send your comments on today's episode or any suggestions you may have for topics or features to communications@cos-sco.ca, and we'll try to incorporate them into future episodes.
EyeCan veut savoir ce que vous en pensez. Veuillez envoyer vos commentaires sur le balado d'aujourd'hui ou vos recommandations de sujets à communication@cos-sco.ca et nous essaierons de les intégrer dans les prochains épisodes.
Thank you from the Canadian Ophthalmological Society.
Merci de la part de la Société canadienne d'ophtalmologie. Our sponsors for Season 6 of EyeCan are Stellus Pharma Canada and Johnson & Johnson Vision. We thank them for their support.
EyeCan is available wherever you listen to your podcasts and, of course, through the COS Practice Resource Center.
EyeCan est disponible partout où vous écoutez vos balados et bien sûr au Centre de ressources pour la pratique de la SCO.
Listening to EyeCan counts for unaccredited MOC credits. Listeners may claim 0.5 credits per hour under Section 2, which is individual learning as educational content review, and that can be done up to 30 credits per year.
EyeCan is written and directed by Kim Teitler and produced by John Allaire from Allaire Strategic Works.
EyeCan est écrit et réalisé par Kim Teitler et produit par John Allaire d'Allaire Strategic Works. Some episodes this season will include relevant links and show notes, so be sure to check episode descriptions to learn more. Certains épisodes de cette saison incluront des liens pertinents dans les notes d'émission, alors n'oubliez pas de consulter les descriptions des épisodes pour en savoir plus.
If any of our listeners have topic ideas to submit, please email them to communications@cos-sco.ca, and we will review for consideration.